from wherever you're speaking to us. Hope you're having a wonderful day for another virtual morning report. We're all so excited. We see so many new faces, and we always love to see that. We usually discuss cases, and if you want and if you can, we would love to have you open your video and have the video open, and so we can have this open discussion with you. It's almost like an invitation for us to discuss with you and ask questions, and that is always welcome. Oh, that's Chloe. Chloe was with me in med school as well.
Hi, Yusuf. How are you?
Good. So good to see you here. Thank you for joining. And I wanted to ask, does anybody have a case they want to present today? It can be in any topic or any field of medicine, and we would love to hear it if anybody has a case.
While people share their thoughts in the chat, I will also say hello and welcome everybody. My name is Rabih. I'm also one of the CPS Solvers team members, and I'm very excited to be lucky enough to anchor these Thursday conferences to orient you a little bit, because I think that there are a lot of new people here. What tends to happen is that we have somebody spontaneously present to discuss a case. You may wonder, that's absolutely crazy. Why would somebody just without preparation just present a case? And I think that goes to show you the environment that we're trying to cultivate here. All of us discuss and think about cases privately. And so why not have a relaxed, low-key environment where somebody casually presents a case and we all discuss and learn together? So welcome to all of you who are joining for the first time. I hope you feel more and more comfortable to turn your video on, to treat us like we hope to treat you, like friends and family members. So welcome, and excited that I get to co-discuss with Yusuf. This is for his first time co-discussing an unknown, and a real honor and a treat to do this with you all. Aisha, good morning. Thank you for turning your video on. Mengyu, hello, and very nice to see you here. I'll call out for one more. You leave it for 30 more seconds to see if anybody has a case they would like to present. My favorite cases are cellulitis, urinary tract infections, no clear diagnosis. And so, yeah, let us know. And welcome to all of you who are joining for the first time. And hi, Marino, nice to see you. Welcome back. I know it's been a while. Saw you yesterday. Hi, Mariana, welcome. Thank you for turning your video on. It's very nice to see you. Okay, well, today there's a special surprise for you all. But before I reveal that surprise, hi, Chloe, thank you for turning your video on. I wanted to tell you something really important, and I wanted to say it publicly. As some of you experience the space for the first time, you'll definitely need a few sessions to sort of feel comfortable with what the space entails. To get a head start, if you're interested, you can check out the videos that we have on YouTube. There's many of them that can give you a sense of what this place feels like. You can make this as a place you come, hang out, turn your headphones in, turn your video off, relax, and listen to medicine, for sure. That's the most casual way. The next layer up is to involve and share your thoughts in the chat. And you can, by the way, do so privately. You can just change your name on Zoom and make it Zoom user or whatever and share your thoughts privately. You can also have your true name and keep it there and share your thoughts that way. You can turn your video on. And of course, the most active way to present is to present a case. It's a very big barrier, I think, to present a case, Yusuf. And so what we have done is, I'll share with you, this is all over social media, but some of you may not be on social media, is we've created a process by which you can actually have a CP Solvers team member mentor you and guide you on how to present a case. I'll leave this up here for a second, and this will be in the email that you all will receive for the next VMR, so you don't have to memorize it. But just know the following. Presenting a case is a tough task, and there are people on this team who are invested in giving you personalized mentorship and how to do that. Why would you do that? There's 3 reasons. The first is, this is a community that has now been 3 years, over around 1,000 cases strong. And it lives and breathes only because people are willing to show up here and spontaneously present cases. So that's your generosity. But practically speaking, it is now, if you are considering applying to the US as an international medical grad, especially, but also for anybody, being able to say that you contributed to something related to CP solvers is a big, heavy thing. It has allowed many people to have very successful matches from within CP solvers. So it is not a small weight on your CV. And then finally, we all know presenting is a really nervous task. It's nerve-wracking even in real life when you're attending with your resident. And so the fact that you get CP Solvers team members to help you do that, curate that case, is a very powerful thing to try to take advantage of. So we really need you to be here and to present this case. Otherwise, this community would not exist. But that need is two-way. I think you'll all grow as an individual, and then you'll also grow very practically and help you achieve your bigger goals. So with that, we're very honored that our dear friend Amanda, who is one of the mentors, mentoring somebody who just sent in a case to review, has a case for Yusuf and I. Amanda, do you mind unmuting and introducing yourself?
Hello, 1 second. Dog problems.
Yeah.
I'm back. Hello, everyone. I am Amanda. I'm from Brazil, and I have a case from today. And it's a very student case and very interesting. Hope you enjoy. And if you want to present a case, let us know and be comfortable. Here is a safe space. Hope you enjoy. So let's start. It's a 25 years old female comes to JD with abdominal pain. The patient related localized abdominal pain in the right flank with nausea, vomiting, which started about 4 hours ago.
Oh, thank you, Amanda. I'm gonna start discussing with this. Thank you for bringing case. Thinking about in general with the 25-year-old female with acute abdominal pain. It's over 4 hours, and we don't have any history if this is the first time happening or if it's happened before. But just by the mere story that it is happening over 4 hours, my alarms are up. Is this something acute that we have to rule out? And in the realm of abdominal pain, I think often anatomically. And if it is in the right flank, I often would think of the kidneys, the ureters, the retroperitoneal space. And I always have to think about the ovaries, I would think of an ectopic pregnancy, for example, and then the intra-abdominal organs. In general, if something is outside the abdominal space, it can also cause these symptoms. For example, something that is cutaneous, like herpes zoster along the flank, happens along a dermatomal distribution, for example. And going deep into the layers, you can think of all of the layers, like I said, the colon, the gut, and then the kidneys and the ovaries and uterus. Rabih, I don't think we can hear you. Sorry.
Oh, sorry. Thank you for catching that. 3 years of a pandemic, and I still have to learn my Zoom skills. I think if you all listen to Yusuf's fantastic discussion, which is essentially quoted in the chat, I think you should pay attention to one thing that he did. He has 2 symptoms. He has flank pain and nausea and vomiting. And the nausea and vomiting did not get any diagnostic attention. And I think that's so reflective of how nonspecific nausea and vomiting is. It can occur from stimulation of the vagus nerve anywhere from head to toe. So you may ask, and you may be wondering, what is the role of nausea and vomiting in this case? And I will share with you what I think the answer is. The nausea and vomiting of this case is like seeing the patient having sinus tachycardia. It doesn't tell you anything about exactly what is going on, but it makes you stand up and pay attention. The fact that the body is responding in this way and as nausea and vomiting increases dramatically the probability of a morbid diagnosis and increases the chances that this disease process lies under the superficial layers of the skin. It takes a really advanced disease at the surface to cause nausea and vomiting, and any disease in the viscera to do so. So for me, Yusuf laid out a very comprehensive landscape of flank pain, and the presence of nausea and vomiting is basically ramping up the severity and the concern and the tempo at which you need to figure this out. So for me, the superficial causes like a muscle strain or herpes zoster are much less likely in a patient who's nauseous and vomiting. Awesome job, Yusuf. Thank you for that comprehensive layout. All right, Amanda, tell us more, please.
So the patient was medicated with improvement and a CT was performed and no abnormalities were seen. The patient was discharged home due to improvement of their heart condition, and it was prescribed tramadol and non-steroidal anti-inflammatory. But one day later, the patient evolved with diffuse headache, nausea, vomiting, malaise, fatigue, and fever. No past medical history, non-meds, social drinker, but non-significant family history, non-allergies.
Wow, thank you, Amanda. And just one question, do we know if the CT was with contrast or not?
Not, I have the CT, but I will show you in the imagings. But if you want, I can show you now.
That's okay. If you want, I can discuss and then we can get back to it. Okay. So now with the history of, so the patient presented to the hospital, they got some pain medications, got better, got a scan and it was negative, and then the next day presented back with headache. And oftentimes the diagnosis of abdominal pain needs to be resolved with imaging. And a lot of times a CT scan is with contrast, and the abdomen is one of the best modalities for abdominal pain in most scenarios. And that's where you go into the realm of image negative abdominal pain, and if that is persistent. And what I love about CP solvers is that a lot of schemas are already established. So if you go and Google image negative abdominal pain for CP solvers, you will literally find a framework for all the things that can cause abdominal pain without anything that is on imaging. And if I want to overlap that with the presentation of headache or the presentation we had the next day of, and I start thinking of things like porphyria, for example, acute intermittent porphyria per se, which can cause, but I don't want to anchor on a diagnosis yet. And a lot of times increased ICP can cause abdominal pain, nausea, vomiting just by increased vagal tone. And these are all things that I think of. Intoxication and ingestions are also one component, for example. And these are my general framework to approach that.
That's superb, Yusuf. You know, I'm really intrigued. I'm really intrigued because if you just guessed that this patient came back after being discharged, I don't think many of us would guess that the reason she came back was because of diffuse headaches, fever, malaise. I think if we were to guess that this patient got discharged and then came back, most of us would probably guess that she came back with recurrent worsening of her pre-existing symptoms, right? So I think it's a really enlightening case to reflect on when somebody comes back very quickly and then comes back with symptoms that are very different than what she came in with originally. And this reminds me of a general principle of clinical reasoning. Most diseases that require acute attention actually begin over the course of a few days. So if somebody presents too quickly to the emergency room, you may catch an incomplete story. You may, for example, somebody comes in with chest pain a few hours after it starts, and only 1 or 2 days later do they notice the rash that's characteristic of zoster. So I'll share with you what I'm doing. I'm removing the ER visit from my mind, and I'm saying, let me pretend that I just saw her from the beginning with no intervention in between. Then the case would be the following. A 25-year-old woman with no prior medical history presents with right-sided flank pain, nausea, and vomiting, with subsequent resolution of her flank pain, followed by a fever, headache, and malaise. And that, oh my gosh, that is a very intriguing, complicated history. And so what I'm doing is I'm following two pathways. One, does she have a complication related to diagnoses in the flank? Or was the flank pain a false localizing sign that distracting us and pushing us to avoid calling this what it might be, an acute febrile systemic syndrome? And I think both those hypotheses will have to track. But importantly, you asked one really, really great question, which is, did she get contrast or not? Because the evaluation of her flank is incomplete without contrast, not assessing for many things in the flank. But even if she got contrast, ovarian pathology particularly is notorious for not showing up on CT and necessitating a good pelvic exam and maybe a transvaginal ultrasound. So there are two questions. Does she have a systemic syndrome and the flank pain was just a distractor? Or does she have an image negative flank pain syndrome that is turned into something else? And it might not be truly image negative. It may be that the imaging needs to be optimized and improved to catch what is otherwise an image positive process. So Amanda, I don't think this is a simple case, my friend. I don't know if I believe you anymore, but please take it away.
So the vitals. Her temperature is 37.9. Blood pressure 120/80. Heart rate is 102. SATs 98% on room air. And cardiovascular, pulmonary, abdominal, it's normal. Abdominal, mild distress, and with Giordano signs positive. I don't know if I'm saying correct, but the patient related pain on the percussion in the right flank and petechia all over the body, especially on their lower limb.
Okay, thank you so much, Amanda. So now with the exam, we have a slightly elevated temperature, a heart rate that is on the higher side. You see the blood pressure is normal. The patient seems in distress and with pain on percussion along with petechiae on the body, on the lower limb. Especially combining the petechiae with the history of fever and the patient having these headaches, my antenna is up for meningitis, the infectious syndrome causing this whole presentation. How do I combine meningitis with the presence of petechiae? So I think of things like meningococcal disease. I think of any bacterial infection like strep, for example, can cause a DIC presentation. We've had multiple cases in the last week of DIC in general that can metastasize to the brain, cause meningitis, and cause DIC. And then the other thing would be a PTP, which is a thrombotic thrombocytopenic purpura, which can cause a similar presentation. If I wanted to go with most likely and what I want to rule out, most likely for me would be something bacterial or an infection. And what I want to rule out is these three things. So I would want to get a CBC, look at the platelets, and then if the patient is if they look fine, I would have to consider an LP, plus minus imaging, plus minus empiric antibiotics.
Oh my gosh, this is you really have to just respect how powerful your reflexes is, Yusuf, to think young woman, headache, petechiae. You have to think of Neisseria meningitis, and it remains one of the most morbid conditions in large part because of early undertreatment. And I think that's absolutely superb. The key thing that our beloved Shima is highlighting and describing is the word petechiae. And I think understanding what that means is really important. And I remember, Yusuf, you shared a great framework for this in a conference led by Rabih. Petechiae is the most counterintuitive thing in medicine because it can represent bleeding in the skin, or it can actually represent thrombosis in the skin. And so it's really hard to know, is there red blood cells that have extravasated out of blood cells, are they bleeding or clotting? And you really need to look for laboratory clues as to whether that is happening or not, whether this petechiae represents clotting or bleeding. However, if the petechiae is palpable, it's much more likely a thrombotic petechia, like vasculitis. So Amanda, can you tell us, are these petechiae, can you feel them or are they non-palpable? Do you know?
Non-palpable.
Non-palpable. So that oh no, go ahead, Amanda. Sorry.
It's when you pressure his thumb and back.
Got you. I'm really glad that they're not palpable, because that means we're probably dealing with a bleeding diathesis. And so it'll be, as you said, Yusuf, really important to understand which one of the two reasons is the patient bleeding. Is the patient bleeding because of an issue in the blood itself, like low platelets or a coagulopathy? Or is the patient bleeding because of an issue in the blood vessel wall? For example, a vitamin deficiency, a malignancy, so on and so forth. So the next key steps will be, what is the CBC and what is the coax, to really help you make an informed decision. All right, Amanda, tell us more.
So the labs: hemoglobin 11, white blood cells 2K with 2 rows, platelets 5,000, PCR 92, creatinine 1, BUN 10, potassium 3.5, AST 146, ALT 123, alkaline phosphatase 80, and GGT 446.
Wow. If I were the physician seeing this patient, I would be a little bit scared, just because seeing the degree of the thrombocytopenia, I see an anemia and I see a low white count. So that all, I could now call it officially a pancytopenia. And with the elevated AST, ALT, and ALK phos, which could be signal to the liver, or just could be a signal to a infection that is ongoing. And my approach to pancytopenia in general is either a systemic infection that is suppressing the marrow, or on the other hand, something that is invading the marrow. Because any systemic infection like sepsis could potentially lower your white count and lower your counts because by mere decreased production, or something that is actually going into the marrow. Like the Maima is pointing out, a smear would be very helpful we would want to rule out hemolysis absolutely, as like that's like an emergency per se. And regarding the liver enzymes, I see the AST and ALT are mildly elevated, and the ALK phos are all like mildly elevated, and none with like significant elevation. So I would keep that in the back of my mind and as part of the workup, but would not definitely consider that as the main signal for me.
Yeah, no, I completely agree with you. I think Yusuf, there's a very profound observation in this case. So we have a fever, right? Basically what I'm going to say, I'm going to argue for is, wow, Amanda, my doggy doesn't like this case. He's worried. By the way, for all those of you who are new to this is how informal we are. I'm wearing my pajama and my dog is barking and nobody cares. So sit back, relax, do whatever you need, and enjoy the conversation. We have a fever, right, Yusuf? And I think basically a fever, almost 38. And whenever you encounter a fever in a patient who's sick enough to be hospitalized, there are 6 very common sources that you have to think about in all patients. Is this pneumonia? Nothing so far. Is this UTI? Nothing so far. Is this cellulitis? Nothing so far. Is this cholangitis? Nothing so far. Is this C. diff, Clostridium difficile? Nothing so far. Or is this a bloodstream infection? And I would make the strong argument that this is a bloodstream infection. Why? Whenever there is a prominent hematological fingerprint of an organism, it's probably in the blood. So when you see that somebody has fever and pancytopenia, especially if it is acute, the probability of a malignancy is so low. And what you're probably dealing with is an infection within the blood. Now, that is a counterintuitive topic because you may immediately say, wait, hold on. Couldn't that just be sepsis, as you just said? And I think the answer is yes. It's either basically an infection in the blood or a vigorous blood-based reaction to the infection. But here, we're not getting any sense of where that infection is, with the exception of the possibility that this patient has meningitis. So what are the possibilities? This patient has meningitis and has a vigorous systemic septic reaction to that meningitis. But it's very unusual in sepsis to have this degree of leukopenia and thrombocytopenia in a younger patient. It tends to be more older patients who get this leukopenia and thrombocytopenia. So for me, I'm like, I really, really wonder if this patient has an infection in her blood. And unlike what we've all been taught in medical school, an infection in the blood is not bacteremia. It's not just bacteremia. It's not just Staph aureus in the blood or Neisseria in the blood. It's actually the very important category of mosquito-borne or tick-borne infections. Where does Lyme live? Where does dengue live? Where does rickettsia live? Guess what? The mosquito or the tick bites into your blood, sucks out the blood, and gives you that infection. So an endovascular infection is often what we think of. We think, oh, the usual bacteremia, but no. Every arthropod, either mosquito or tick-borne infection, is totally fair game here. Totally fair game. And I'll tell you that the reason that should cross your mind is a very subtle but important observation. Most of the time when people get pancytopenia from non-arbo infections, their hemoglobin, white blood cell, and platelet counts are proportionally depressed. In this patient, that's not the case. In this patient, the hemoglobin is the closest to normal. In fact, for a young menstruating woman, it might be almost normal. This patient doesn't just have pancytopenia. She has, be very careful, watch this observation. This is a disproportionate leukopenia and thrombocytopenia with mild anemia. And that is a very characteristic fingerprint of arthropod-based infections. They cause much more suppression of the white cells than the platelets compared to the hemoglobin, with the exception of malaria, Babesia, and Bartonella bacilliformis, an infection mostly found in Peru and in Ecuador. So I'm curious, Yusuf, what do you think about that hypothesis? And if you're in agreement, how might you play around with it in real life?
So I think the whole labs are fit into the hypothesis, like the elevated liver enzymes, the low white count, the low platelets fall into that hypothesis. And this is where I might consider quickly ordering serologies and blood work and potentially starting antimicrobials empirically until we get further workup, particularly doxycycline, which covers a lot of these organisms per se. So I might get the blood work, start some antibiotics, make sure the patient is covered, and at least covered for meningitis along with the tick-borne illnesses, and then do the workup in the meantime.
For all of you joining VMR for the first time, Yusuf leads a series called Management Reasoning, where the focus is much more on how to treat the patient as you figure out what diagnosis you have. And you just saw that in real life, he would have maybe saved this patient's life. This person, before we hem and haw, in the United States, this person, because of how many tick-borne infections we have here that are lethal, this person should get doxycycline. And if this person were in the United States, that move would save their life, probably. But Yusuf, I'm really curious. We don't know where this patient is from yet. So maybe Amanda, you can give us some history. What is the epidemiology of this patient? Where is this patient located?
From Brazil.
Yusuf, does that do anything for you?
I think I would try to think of a lot of like dengue, for example, although we don't see any signs of vascular leak or anything like that. When I would go to the CDC website and look at endemic organisms to the area that the patient is coming from, essentially. And that is something I recommend. You're not expected to know every single bug from all the world, but you should know to like, oh, I can just Google CDC-Brazil-area and you can find all the endemic organisms.
I think you're absolutely right, my friend. As soon as I saw that count, I was really worried about dengue. I'll tell you why. The patient has relatively preserved hemoglobin, and that may be the early phases of vascular leak. So what is vascular leak? It begins on a spectrum of initially just leaking fluid that is non-hemorrhagic, just transudative fluid. And so the hemoglobin goes up, and then the patient bleeds. So for me, I'm a little worried that the relative hemo concentration compared to the leukopenia and thrombocytopenia might be a clue for dengue. And if you look at case reports of dengue, an abdominal presentation with flank pain is not uncommon. It's very intriguing. I'm not sure why. So I think in this patient, what would that change in terms of my management? I would start aggressive fluid resuscitation right now. A lot of fluids, lot, much more than I would otherwise, for that possibility and trend, and pay very close attention to the hemoglobin. Because in most circumstances, when the hemoglobin improves to 14, 15, you're happy. In this circumstance, if the hemoglobin improves to 14 or 15, you might worry. That means the patient is having more vascular leak and needs more fluids. It's a very counterintuitive situation. But I think that hemoglobin is really, really intriguing. But anyway, we've rambled a lot. Amanda, tell us what happened next.
So we have more exams. Total bilirubin 0.3, direct bilirubin 0.1, indirect bilirubin 0.2, ERN 1, PTTA 31, pregnancy test negative, urine analysis normal, and the CT scan, it's normal. I can show you the CT. Please, 1 minute. What? Where is my video? I'm sorry.
Oh, take your time, no problem.
Fine. Mhm. Huh. Here. You can see? Let me take this phone. Huh. I think I can. Here.
Thank you, Amanda. It looks very normal. Awesome. Thank you so much.
So it's normal. Actually, the CT was performed thinking in kidney stone, but there is no stone. And fluid was started, a lot of fluid, and the patient evolved with gum and vaginal bleeding, and the discomfort worsens. So she was hospitalized, and some cytologists was asked, I give you the final diagnosis, or?
Well, maybe you can have Yusuf reflect on this information and then you can tell us the answer. How does that sound? All right, Yusuf, what do you think?
Yeah, thank you, Amanda. I think the imaging that is negative and the fever and the whole syndrome confers our suspicion if this is most likely an acute infection. And the highest on our differential is dengue fever. And a lot of times we have to manage the complications before diagnosis, like we said. So we have to manage the bleeding, make sure the bleeding is under control, make sure we give the appropriate antibiotics, fluid resuscitation. And my highest diagnosis would be dengue fever. And that would be my working diagnosis at this point.
Yeah, Yusuf, I completely agree with you. As a framework, you can now say, in the absence of DIC labs, this person likely has a viral hemorrhagic fever. Viral meaning you haven't found out where the bacterial infection is, and now she's hemorrhaging. And so you can literally quickly Google what are the causes of viral hemorrhagic fever, and there aren't that many. And I completely agree with you. Based on the epidemiology of this case, dengue seems by far and away the most likely. Awesome job. Yusuf, what's your, just before we hear the case from Amanda, what's your reflection on how the case, where you were mentally with the first aliquot and then where it ended up? Like, how did that journey land in your mind?
Amazing. I can't imagine the first provider who saw her in the ED. What did they think if we told them like a couple of days later that this patient actually turned out to have this entire syndrome? I think the first presentation was we couldn't have predicted what was the direction the patient was headed, and that we had the test of time. And the test of time told us how it perspired and what happened afterwards. And I think that was amazing. And the geographic location also was very helpful for the infectious syndrome in this case.
Yeah, absolutely superb. I really have one really important piece of advice for everybody listening. When a patient presents acutely, very quickly after they get sick, you have to recognize that they may be coming in only having read half the chapter of their full story. And that half chapter can be so different from the final chapter. Initially, this case was just flank pain, then it becomes a systemic syndrome. So be very, very careful of that. I see Amanda has turned her video off, so she may not be available to tell. Oh, yeah, you are. All right, Amanda, tell us more.
So she was hospitalized, and IgM and IgG for dengue, Zika, chikungunya were done, and being IgM and IgG positive for dengue, closing the diagnosis with hemorrhagic dengue.
Yusuf, thoughts? What do you think?
I'm mind blown. Thank you so much, Amanda. That's a really, really good case.
How did the patient do, Amanda?
Super great. Oh my God. She is at home now and super safe and healthy.
Good, good. I'm very, very, very glad to hear that, Amanda. Very, very glad to hear that. Really, really educational case. It's a real treat to have you presented. And I'm really curious, Yusuf, how did it feel to discuss your first case?
It was a little bit scary, but it feels good to be amongst family. And it was really nice to go through the spectrum of, we went through flank pain, abdominal pain, image negative abdominal pain, then petechiae and fever, and then petechiae and fever in a patient with low white count, low platelet count, and elevated liver enzymes. And we went through 5 or 6 differential diagnoses in one case, if you think about it. And you were able to talk about all of these in one case, which is just like mind blowing.
No, I couldn't agree with you more, Yusuf. And it was a real treat to have so many new people joining us today. We really hope that you had a good time. And we hope that you consider spreading the word about this initiative. It really is meant to get all of us to be better doctors and better humans and form a really good community here. And remember, we lean on you all to present a case. So each of you who is joining for the first time today or joining for the 10th time or the 30th time, ask yourself, what case can you present next time? We'll need it, and really hope we can count on you. And if you want some help from us, we will be there personally to help you put your case together. Take a look in your email inboxes soon, where we'll have the visual of what we showed you today in the email. And last thing we do is we go through the major teaching points to emphasize them one more time. And for that, we have our dear friend and CP Solvers team member, Noah, to take us through the journey.
Hello, everyone. So very interesting case and amazing discussion. It felt like you guys knew the ending of the case at a few points. So today we talked about how the acuity of the pain is alarming. Also nausea and vomiting, although non-specific complaints, they should trigger us to think of a very severe problem. As superficial complaints don't usually cause those systemic manifestations. So we started off talking about the abdominal pain. One possible approach is anatomical. Think of all the layers you can go through until you reach the other side of the body. So you can have skin involvement, fat, muscle, bones, nerves, intraperitoneal organs, retroperitoneal organs, etc. We also talked a little bit about the image negative abdominal pain. It has a few buckets: metabolic, meds or toxins, functional, and other. But then we took a step back and we reframed the problem by using the dimension of time. And we came up with 2 possible hypotheses. So we could either have a flank pain disease, be it image negative or not, with systemic complications, versus systemic illness with tangential flank pain. And then we didn't focus too much on the flank pain, and we tried to keep our minds open for the second possibility also. Once we got more data, we found out the patient had petechia, fevers, and headache. And this should alarm us for the possibility of meningitis, which is a very morbid diagnosis, and we don't want to miss that. Both meningococcal and other forms of meningitis, if severe enough, can cause this presentation. We talked a little bit more about the petechias. So they can be caused by a problem of the vessel, either inflammation, like a vasculitis, or a nutrient deficiency causing a vasculopathy, for instance. The petechial rash can also be caused by a problem of the blood, be it platelets or the clotting factors. This patient didn't have a palpable petechial rash, so we thought more of hemostasis problems. Once we got the labs, we saw that the patient had pancytopenia. Pancytopenia can be caused by 3 big buckets. So either marrow infiltration, marrow failure, or peripheral destroying process. But this case had a very important clue that pointed us towards a possible diagnosis, which was the disproportionate decrease in white blood cells and platelets compared to the hemoglobin. So Rabih mentioned that this points towards us a arthropod-borne infection, which was the case. We also quickly went through fevers that can cause hospitalization. So pneumonia, UTI, cellulitis, cholangitis, C. diff, or bloodstream infections. In this case, we didn't have any signs that pointed towards other possibilities, so we focused more on bloodstream infections. And based on the epidemiology and the presentation of a febrile hemorrhagic disease, dengue fever became the #1 possibility. So dengue clinical manifestation occurs in 3 phases. So we have the febrile phase, which the patient has malaise, fever, headache, retroorbital pain. After the fever ends, we enter the critical phase, where we have vascular leak, the bleeding manifestations, abdominal pain, lethargy, agitation, which is called the critical phase. And then we have the recovery, which can have fluid overload manifestations. Management is largely supportive with fluid resuscitation and managing the bleeding complications. And that's all I have for today. Thank you, guys.
No, I hope you took a look at the chat. That was absolutely superb. You got some big shout outs. Thank you for superb teaching points and your radio voice, which Yasmin would recommend you put to an audiobook use or something like that. Well, thank you again, Amanda. Thank you, Yusuf. Thank you, Noah. We really hope to see you all next time. We unfortunately are not around tomorrow as Reza and I are at a conference, but we'll be back for student VMR on Sunday and then back every day next week. Bye.